That's a nice and quick one. Just not too taxing on the brain. Gastroenterology is not smart stuff, but cha-ching. Barrett's esophagus. We talked about this a little bit yesterday. Acid comes up in the lower part of your esophagus, keeps on irritating it for long enough. The cell changes from your normal squamous type, and this is what all the questions are asked on, is it goes from squamous through a process of metaplasia, which just means change, into columnar-lined intestinal, gastric or intestinal type cells. So that sums up probably the big chunk of questions that you're going to be asked, because everybody always forgets what the native type of cells are in the esophagus, which is squamous, and the fact that you're turning it into secretory, gastric or intestinal columnar-lined cells. So much so that in America they've tried to make their job a lot easier, and they've called it cloesophagus. Columnar-lined esophagus makes it easier. If it's in the name, you're never going to forget. What should you not mix this up with? Your Clo test, where you do an endoscopy, you take a sample, you put it on a pregnancy type test, you wait for the little stripes to come up, and that tells you whether you've got it or not. So columnar-lined esophagus. So you start off with normal squamous. You go through a process of metaplasia. You then end up with columnar-lined cells. The theory is given a long enough period, it will go through a process following metaplasia of dysplasia. And then you'll have mild dysplasia. That process continues on of dysplasia, and then you end up with high-grade dysplasia. And what we do in England, as we talked about, they do it differently in Japan, is people, when they get columnar-lined esophagus, this is when they've got Barrett's, in some places, we put them into a Barrett screening program, and we bring those people back every 2 years. It goes anywhere from 18 months to 3 years, depending on what hospital you work in. It's supposed to be 18 monthly. Every 18 months, you bring them back and you do another scope, OGD, and you take lots of little biopsies. Take little biopsies every centimetre, 4 different places, all around the edge. Every centimetre or 2, all the way up the esophagus. And you look at those under the microscope, and what you're looking for is, has it become dysplastic yet? And so you carry on monitoring it every single 18 months and having a look. And when you get mild dysplasia, or low-grade dysplasia, at this stage we say, okay, well, we're going to zap it with a laser. That's what we're going to do. Go down, bzzz, or you use some heat. You do something to try and zap the cells that you've got mild-grade, low-grade dysplasia. And you go back and you monitor now more frequently because you're worried they got mild, low-grade dysplasia. So you're going back and because you're thinking it's going to turn into this. So you go back more frequently, having a look a little bit more. If you have a number of OGDs saying that we've gone back to this stage, then you turn back to every 18 months or 2 years, going back and having another look. If at any point you get to the high-grade dysplasia is found, what do? We cut out the esophagus. If you're fit enough and young enough, we go in, rip your chest open, cut out your section of esophagus, pull your stomach up into your chest, stitch the two together. Your stomach is now in your chest. You haven't, reflux is going to be your life for the rest of your life, and you probably have problems with infections because that leaks. Horrible high mortality associated with that operation. And that's Ivor Lewis esophagectomy. That's what it's called, an Ivor Lewis. In the exam they'll call it an esophagectomy. Of course, in Japan they've got this all sussed. And they say, if you've got columnar-lined esophagus, what we do is we've made a piece of equipment that will slip down. It's got little wires around the outside of it. We cook about 1 millimeter of the inside of your esophagus, so it all dies and it all falls off. It's painful and you can't have a drink or you can't eat smoky food. We'll pull it out and then we go back and we look about 6 months later and it's all grown back to absolutely normal. So your esophagus looks absolutely normal. Now you haven't got Barrett's anymore. We'll have a look in another 5 or 10 years. If you've got Barrett's again, then we'll do it again. But now you're low risk, so we won't bother about it. So they do it back here. They also say when you've got high-grade dysplasia, by looking at it, I can say by looking at it whether that's metastasized or not. If it hasn't metastasized, I'll get a little suction cup, suck the inner layer of the esophagus up, just remove that, leaving the muscular layer. That all heals up very nicely, and the survival rates are much better. When we look at numbers, we'll say, okay, we monitor all of these people and do hundreds of OGDs. And when we find high-grade dysplasia, which may end up resulting in the person having a cancer and dying, we rip out their esophagus, and lots of people die during that process. When we add up the numbers, this monitoring process for Barrett's has never been shown to improve mortality at all. So it's very expensive, and rarely, if I had Barrett's, would I want it monitored? I don't know. Because if they found something nasty, they'll probably err on the side of caution and they'll take my esophagus out. So I may never have problems with it in the future, but if it's monitored, I may end up with an esophagectomy and die of that. I may never have the problem with the esophagus, but I may end up with it out. So that's where we are at the moment. Our monitoring, we use a system called the circumferential and maximal. It's a Prague. Circumferential and maximal criteria of grading Barrett's esophagus. And all that means is whenever we go down, we have a look and we see what the maximal, how long it goes down for and how much of the circumference it goes around for, and then we can grade its severity. And each time we go back, we monitor to see whether it's getting more severe or not. There's no, with quadrantic biopsies. Now this is all caused by acid refluxing up into the esophagus. So just a quick, at the top there, GORD, gastroesophageal reflux disease. The definitive test for that is to do esophageal manometry. So esophageal manometry looks at the pressures of things in your esophagus, but you can also do pH monitoring where they put a little tube down and they measure the pH. What we found is that people who rarely complain lots of having reflux are at no higher risk than people who never complain of having reflux. Symptoms of reflux aren't very well associated with the severity of the reflux that you get. So if you think, I get reflux all of the time, you're at no higher risk of ending up with Barrett's esophagus as you are if you never complain of symptoms. But those people who are complaining of symptoms, we can do esophageal manometry. They end up being those mad people who keep on complaining, and no matter what you do for them, they'll keep on complaining. We end up doing esophageal manometry and pH study to show that the symptoms that you're getting aren't really related to any severe amounts of esophageal reflux. So that's the gold standard disease, rarely to shut people up. But I didn't hear that from me. If you do end up finding that they get really, really big spikes of reflux at the same time as they keeping a diary and complaining of symptoms, then you can start to think of doing other things. But they do boil down to really basic things, putting books underneath the end of your bed, your PPI therapy, and you really want to avoid doing big operations to try and increase the effectiveness of the sphincter that borders the transition between your esophagus and your stomach. The other bit that comes up is the chain of acid secretion in the exams. What causes acid to be secreted? Vagal nerve. That causes, and you're going to need to change in your book. I've written enteral G cells, and it's not, it's antral G cells. Does it say antral? With an A, antral. Does it say that in the book?
Oh, what it is it's in the box.
Yeah, it's in the box, it's correct, but in the little spiel it's not. So the vagal nerve, vagus nerve, antral cells, so this is your stomach, this is your lesser curve, this is your greater curve, this is your pylorus, and over here, This is your antrum. Pyloric antrum. Now the antral G cells secrete histamine. Sorry, secrete gastrin. Gastrin B. Gastrin B works on your enterochromaffin-like cells, ECL cells. And it causes them to secrete histamine. Histamine then works on parietal cells, which secretes acid and intrinsic factor. So we now have drugs that can irreversibly damage proton pumps, but because they're replaced about every 24 hours, you get a new set of proton pumps. That's why you need to take your proton pump inhibitors every day, because they need to damage the new set of proton pumps that are being produced. You can now see why we used to use antihistamines. And those are drugs like ranitidine, and you still see ranitidine being used. Clinical practice is not helpful for your exam at all, but if you give omeprazole will decrease people's acid secretion over the next 6 to 8 to 12 hours. If you give ranitidine, your acid production decreases almost instantaneously. So within half an hour, you've decreased it. If I've got symptoms now, there's no point me taking an omeprazole. My omeprazole that I take is going to help me with my symptoms tomorrow, and then I take it every day to keep it under control. But if I want to get rid of my symptoms, then an antihistamine, ranitidine, is going to be much better for it. I'd like to bring your attention quickly to the achalasia section. Now, for some reason, they love asking questions about achalasia in the exam. And the reason being is because they can get you to choose one of those 3 investigations depending upon how they word the question. So they can say that somebody comes in, and achalasia classically is a dysphagia to solids and liquids from the start. It's a problem with the plexus of nerves that sits in between the layers of muscle in your esophagus. And you get disorganized contraction and very tight lower esophageal sphincter pressure. Now, if somebody comes in and complains of dysphagia, whether it's to solids and liquids from the start, you at the top of your list, you should never go for achalasia as your first diagnosis. If somebody complains of dysphagia, they've got cancer until proven otherwise. So if the question is, they paint a rarely pretty picture of achalasia and they say, what is the definitive investigation to prove the pathology that you suspect? The definitive investigation is esophageal manometry, is to actually measure the pressure of that lower esophageal sphincter. If they ask you the question is, what is the first investigation that you'll do? Well, if they were young, I would do an OGD. Like anybody who comes in with dysphagia ends up with an OGD. You don't see somebody suddenly come in and they'll say, we'll do esophageal manometry. The first investigation is always going to be an OGD to rule out whether they've actually got a cancer, pseudoachalasia. They've just got a big tumor sitting there. If they're elderly or they don't want an OGD, it's sometimes quite helpful to do a barium swallow, because a barium swallow will outline the abnormality that's there. But you're not going to be able to get a tissue diagnosis by doing a barium swallow. So just be aware that you get a characteristic feature with a barium swallow. You get a rat's tail. That with endoscopy, that's going to be the first investigation that you're really going to do because you want to prove that they haven't got cancer first. And finally, that the definitive investigation is esophageal manometry. So barium swallows are good to see whether there is something wrong with the function of the esophagus for the way that it works. But it doesn't really provide you with much more information. It's usually the test that you do after you've done all of the others. Now, in the bottom right-hand corner, there's substances that inhibit gastric acid secretion. The one that's most important out of that box is somatostatin, because somatostatin is the universal inhibitor of everything in your gut. It stops acid, it stops fluid being secreted, it stops everything being secreted within the bowel. That's why it's often used when surgeons make holes in people's bowel and they end up with fistulas. They put them on somatostatin to decrease your fistular output, and hopefully it will heal. And it never does. They always end up going back to surgery, but it buys them a little bit more time, and they can think of a medication which makes them feel clever. And then it's all of the three-lettered acronym and CCK, GIP, VIP, those other things decrease acid secretion, but the most important one is somatostatin. I would also draw your attention to secretin as well. Because of its name, secretin actually works, it makes the pancreas secrete alkali substance and also proteolytic and lipogenic substances. Whereas so secretin, in your head you think, that sounds like something that would make you secrete gastric acid, but it doesn't, it turns it off. Somatostatin, the universal inhibitor of everything. Going to the take-home points box. Barrett involves metaplastic change of esophageal epithelium from squamous, which is the normal lining, to gastric or intestinal, so it can be described as gastric columnar line cells or intestinal columnar line cells, in which adenocarcinomas can develop. Now, if this is your esophagus, this is the top part of your stomach. The vast majority of esophageal cancers that develop in the middle third, and those are squamous cell carcinomas. So the most common type of esophageal cancer is in the middle third. Ones that occur in the lower third are usually the ones that occur because you've had gastroesophageal reflux causing Barrett's esophagus. And that one in the lower third is adenocarcinomas. Now, because you've had a change from squamous cell, that's why you no longer get squamous cell carcinomas, because you've got secretory cells. Secretory cells turn into adenocarcinomas. Adeno meaning glands, a glandular type of cancer. Now, this was by far and away the most common, and this is approaching and almost equaling its incidence now. But if you had to pick, if they said, which is the most common type of esophageal cancer, squamous cell carcinoma still is. So, stimulation of gastric acid is an indirect process. The vagus nerve stimulates antral G cells in the pyloric antrum. They secrete gastrin B. That stimulates enterochromaffin-like cells, which release histamine. And histamine stimulates parietal cells to secrete acid and also intrinsic factor. Remember that you can get pernicious anemia both from antibodies towards the parietal cell, but also acid towards intrinsic factor as well. And we talked about how pernicious anemia was a risk factor for gastric cancer. It was one of our 3 A's. It was blood group A, nitros A means, and pernicious anemia, as well as all of the other gastroenterological conditions like celiac disease, HNPCC, and familial adenomatous polyposis coli. One of the things that reduced the frequency of this was H. pylori, because you tended to get atrophic gastritis and hypochlorhydria. It decreased the amount of acid coming up into this. So actually, H. pylori decreased your rates of esophageal cancer, sadly increased your rates of gastric cancer, and you could also get malt cell lymphoma from it, which you cured by giving therapy with amoxicillin, clarithromycin, and a proton pump inhibitor. All of those are given twice daily for a period of 7 or 10 days. Metronidazole isn't first line, that's only used for people who are allergic to amoxicillin. So the fourth point is release of hormones from the duodenum as well as the pancreas act as a feedback mechanism, reducing acid secretion, which is our inhibit acid secretion box at the bottom right-hand corner. Achalasia classically presents with dysphagia to solids and liquids from the start. Okay, we're going to do the question together, and then we're going to stop for a tea break. A man has had a 20-year history of gastroesophageal reflux disease. Occasionally, following vomiting, he has noticed a small amount of blood mixed in with the vomitus. It had been explained to the patient that on endoscopy, columnar-lined cells had been found. You are questioned by the patient, who has researched the matter from lay documentation found on the internet, and it's lovely when people do that when they come in and they bring a wodge of things that they've read off the internet. Which of the following information found on the internet about his likely diagnosis is true? A. By definition, dysplastic changes are required in order for this diagnosis to be made. No, it's metaplasia that occurs in order for somebody to get Barrett's. As soon as they start getting dysplasia, you're going to think about burning stuff and eventually taking their esophagus out. This condition more commonly causes squamous cell carcinoma rather than adenocarcinomas. No. When you get a change to a secretory cell, this is now columnar-lined secretory, gastric or intestinal type cells, they turn into adenocarcinomas, but the middle third is squamous cell carcinomas. A lower incidence is found in those with a positive urea breath test. Is a lower incidence of Barrett's found? Yes, it is. Also lower incidence of esophageal cancer, adenocarcinomas. This condition, meaning Barrett's, is predominantly the consequence of a congenital abnormality. No, it's acquired, isn't it? You keep on getting gastroesophageal reflux disease. In fact, those people with Barrett's, if you make lifestyle changes, you can have a good regression of their Barrett's. So it's not, it's acquired and usually a lifestyle. This condition is associated with a 300% increase in the risk of esophageal cancer. Well, we've already found the right answer, so it's not associated with a 300. A 300 means that you have a 3 times higher risk of esophageal cancer. Now, if you only had a 3 times higher risk, then we wouldn't bother screening people for it. Because you get a 3 times higher risk of a lot of things just through lifestyle things that you do. So we wouldn't change it. It's in the region of 30 to 50 times the risk. So it's this figure that people look at when they would think, yes, monitoring people is a really, really good idea, but just from your non-exam work hasn't really shown to have a mortality benefit. And gastroenterologists are quite happy to admit that. Yep. Any questions? So if we stop for tea break, you may find